So vulval lichen simplex. So this vulval lichen simplex generally happens on some underlying conditions. So there may be underlying dermatosis such as atopic dermatosis, allergic contact dermatitis, or superficial fungal infection. Or there may be underlying systemic condition like renal failure, thyroid dysfunction, biliary disease, or Hodgkin's lymphoma, etc. Or environmental factors such as heat, sweat, friction, irritants, and psychiatric factors such as anxiety, depression, OCD, or emotional stress triggers each scratch cycle. So when you talk about this lichen simplex, so lichen simplex, generally there is an underlying condition which may be either systemic condition or mental health related condition or underlying cutaneous dermatosis or environmental factor. So three underlying condition and one environmental factor such as, so these are the different types of underlying conditions where this lichen simplex develops. So underlying conditions like allergic dermatitis, atopic dermatitis, or fungal infection. Very systemic disorders in which there can be renal failure, biliary disease, or thyroid disorders, etc. And psychiatric conditions. Okay, symptoms are similar: vulval itch, soreness. Signs, you get a lichenification, thickened and pale scaly areas, erosions, fissures, excoriations, hair loss in the scratch areas. Complications, secondary infection can happen. Diagnosis is mainly by the clinical presentation. History, including mental state, is indicated. So, general skin examination for other lesions or psoriasis. Further investigation, for infection if you suspect Staphylococcus aureus or Candida, and dermatology referral for patch testing. Ferritin levels can be done. Biopsy if the lesion is atypical. Okay, so these are the additional investigations you can do. Treatment is avoid triggers. Emollient soap such as hydromol can be used. Topical steroids potent for lichenified areas for limited duration. Okay, combination of antifungal antibiotic. So almost same kind of treatment is there, but lichen sclerosis and lichen planus, generally this clobetasol propionate is definitely required. Here lichenified areas will require topical corticosteroids. Okay, if there is a associated infection, antifungal antibiotic will be required. And because of the mental health association, mild anxiolytic antihistamics will be required, and CBT will also be required. So follow up mild disease as clinically required. Severe disease you have to review after 1 month. Okay, and you will give the patient written information to all patients. Target is 100%. That is same for all conditions. Now we'll compare all these three conditions along with the eczema. So there are total vulval eczema. So total 4 conditions we will compare. See, the lichen sclerosis we have seen, lichen planus also we have seen. Now let's see the key signs. Here it is a white atrophic plaque. There is a thinning of the skin. There are purpuras and fissures. Here in lichen planus, it may be classical, hypertrophic, or erosive. In erosive, you have got a mucosal erosions, Wickham striae, vaginal involvement. So vaginal involvement will differentiate from the lichen sclerosis and the lichen planus. Okay, so one vaginal involvement, Wickham striae, Mojave lesions. So these are the mucosal erosions. Okay, so these are the typical buzzwords for the planus you remember. Symptoms, most of these are similar, but because the mucosa is involved, you may get the postcoital bleeding, discharge, etc. in lichen planus. Biopsy, you need to remember differences. There is a thinning of the epidermis, subepidermal hyalinization, and lymphocytic infiltrate. While in planus, you will get the sawtooth acanthosis, basal cell liquefaction, band-like lymphocytic infiltrate, and direct immunofluorescence if you suspect the immunobullous lesion. Okay. Then standard treatment is same for both. Here review is required at the end of 3 months and then annually once the condition is stable. It is also almost similar. Initial review 2 to 3 months and long-term follow-up for erosive disease annually if the patient is stable. So I hope you will be able to remember these particular features because you need to select appropriate diagnosis. Okay. Next is a vulval eczema. Vulval eczema, you have erythema, lichenification, excoriation, fissures, etc. Symptoms same, itching and soreness. Diagnosis is mainly clinical. Patch testing is required for contact allergy and biopsy if the lesion is atypical. Now here in eczema, the treatment will be different. Treatment will be weak steroids. Up till now, the strong steroids were required. So main is avoid triggers, emollient soap substitutes like hydramol, topical corticosteroids, hydrocortisone 1%, bitmethasone or clobetasol can be used, antifungal antibiotic if there is a secondary infection. Okay. While in lichenified pale scaly skin, erosions, fissures, excoriation, hair loss in a scratch areas. Okay. And itching, soreness, these are the symptoms. Diagnosis is mainly clinical. Patch testing if we suspect the allergy. Biopsy if the lesion is atypical. Avoid triggers, treatment, and emollient soap substitutes. Potent topical steroids for lichenified areas. Mild anxiolytic antihistaminics are required, and CBT is also required because lichen simplex is associated with either underlying systemic condition or underlying dermatosis or underlying mental health condition, or it may be environmental condition also. Okay, so you need to have appropriate treatment, and follow-up will be mild disease as clinically required. Severe disease we will review at 1 month. Okay, that is the lichen simplex. So that finishes the benign conditions of the vulva.